My name is Neil Lakdawala. I'm a cardiologist at Brigham and Women's Hospital and Harvard Medical School. I specialize in the care of patients with inherited disorders of the heart and blood vessels, and we'll be discussing cardiomyopathies. Here are my relevant disclosures. The approach to a patient with cardiomyopathy starts with characterizing the type of cardiomyopathy. Different rubrics for categorizing cardiomyopathy have been established and disseminated in the preceding decades. The most contemporary version was provided by the World Health Organization and classifies patients in 4 domains, the MOGE system. Those 4 domains are M for morphofunctional phenotype, and that specifically refers to the pattern of remodeling present in the ventricle. O stands for organ system involvement, questioning whether there is disease beyond the heart or heart alone. G stands for genetic inheritance pattern, and E stands for etiology, so this could be the specific disease gene or underlying pathophysiology. In today's lecture, I'm going to focus on several different cardiomyopathies which fall within the MOGE rubric, including hypertrophic cardiomyopathy, dilated cardiomyopathy, and then cardiomyopathy caused by either inflammation, myocarditis, or amyloidosis. Starting with hypertrophic cardiomyopathy. This is defined as left ventricular hypertrophy not secondary to abnormal hemodynamics. In other words, not due to uncontrolled hypertension or aortic stenosis. The working diagnosis is for a degree of left ventricular hypertrophy, generally greater than 13 to 15 millimeters in maximal wall thickness, and typically, this pattern of thickening is asymmetric, involving the interventricular septum to the greatest extent. However, different patterns of ventricular involvement have been well described in hypertrophic cardiomyopathy. The prevalence of this disorder has varied based on the ascertainment method, with reported prevalence ranging from 0.02 to 0.23%. Amongst families with identified hypertrophic cardiomyopathy, we've appreciated an autosomal dominant pattern of inheritance with delayed penetrance and variable clinical expression, such that carriers of disease-causing mutations or alleles do not develop disease, in this case ventricular hypertrophy, until later in life, hence the delayed penetrance. And variable expression because the severity of the phenotype or of cardiomyopathy can vary within even individual families. We've learned over the past 30 years that hypertrophic cardiomyopathy is a disease of the sarcomere. This cartoon is of the molecular motor of the heart, or the sarcomere, which can be divided up using electron microscopy into different domains, including the Z disc, the M line, the A band, and the I band. Shown here in green and yellow are the thick and thin filaments, which slide across one another to underlie ventricular contraction. The principal genes encoding thick and thin filament proteins include MYH7, MYL2, MYL3, and MYBPC3 for thick filaments. And for thin filaments, the principal genes are TNNI3, TNNT2, TPM1, and ACTC1. In hypertrophic cardiomyopathy, the vast majority of disease is caused by mutations in the thick filament encoding genes MYBPC3 and MYH7, which encode binding protein C and myosin heavy chain. Our understanding of the natural history of hypertrophic cardiomyopathy has evolved considerably in the past several years. While initially reported to have a particularly adverse prognosis, subsequent studies highlighted a generally favorable prognosis, not much different than the age-matched healthy U.S. population. However, utilizing a much larger scale, Dr. Carolyn Ho and colleagues examined the natural history of hypertrophic cardiomyopathy in a cohort of over 5,000 patients. And here, she showed that in all age groups with hypertrophic cardiomyopathy, there's a higher rate of death compared to the age-matched U.S. population without disease. And beyond whether or not one has hypertrophic cardiomyopathy, the identification of a sarcomere gene mutation, which is present in approximately 50% of people with HCM, is associated with an increased risk of adverse outcomes. So with that natural history in mind, how do we approach the care of patients with hypertrophic cardiomyopathy? We assess for symptoms and manage them. We identify patients at high risk for unanticipated complications, including sudden death and stroke. And we assess family members to determine if they too have disease and merit the same management principles. Underlying symptoms is often left ventricular outflow tract obstruction or hypertrophic obstructive cardiomyopathy. This is caused by contact between the anterior septal leaflet of the mitral valve and the interventricular septum during systole. This causes flow acceleration through the left ventricular outflow tract and a pressure gradient between the left ventricle and the aorta. This can be quantitated using Doppler echocardiography, and it's important when doing so to distinguish an outflow tract obstruction gradient from a gradient caused by mitral regurgitation. A gradient should be measured at rest, with Valsalva, and with exercise, because a considerable number of patients with HCM will not have obstruction at rest, but will have it under provoked circumstances. Nevertheless, not all patients with hypertrophic cardiomyopathy have obstruction. Approximately 1/3 to 1/2 of patients have non-obstructive HCM. Amongst patients with obstructive HCM or symptomatic LV outflow tract obstruction, medical therapy and mechanical management is often effective at ameliorating symptoms. First-line therapy is treatment with beta blockers or calcium channel blockers to diminish contractility and relieve outflow tract obstruction. While large randomized controlled studies underlying the success of this therapy strategy does not exist, the ACC and AHA consensus guidelines recommend beta blocker and calcium channel blocker therapy as first-line treatment. In particular, L-type calcium channel blockers, verapamil and diltiazem, should be used, as vasodilating drugs such as the dihydropyridines may actually exacerbate outflow tract obstruction. Where beta blockers and calcium channel blockers are ineffective, disopyramide can be added as a second agent in combination with one of the two. And where patients fail therapy with medications, referral for mechanical management or septal reduction therapy, either with surgical myectomy or alcohol septal ablation, may be indicated. It is estimated that approximately 5% of patients with obstructive HCM may develop medically refractory symptoms which merit referral for septal reduction therapy. However, this is not a treatment that's indicated outside of medically refractory symptoms. Beyond using medications and surgery to treat symptoms, it is important to avoid the physiology which could exacerbate outflow tract obstruction, in particular vasodilating drugs, as mentioned earlier, and scenarios which could cause dehydration, which sometimes could include medically induced dehydration with diuretics. Disopyramide was mentioned as a second-line therapy for obstructive hypertrophic cardiomyopathy. This is a drug that's not commonly used in practice outside the purview of hypertrophic cardiomyopathy, and it's useful to review its pharmacology and utility in this patient population. Disopyramide was originally developed as an antiarrhythmic. It is a 1A antiarrhythmic with potent sodium channel blocking properties. This in turn leads to a marked reduction in contractility, and this indeed is the pathophysiologic basis for its use in hypertrophic cardiomyopathy. Amongst patients studied with obstructive HCM and treatment with disopyramide, approximately 2/3 will have a symptom benefit with an associated reduction in gradient with the use of disopyramide. This is typically prescribed in the long-acting formulation, which is dosed twice daily, and in a total daily dose of 300 to 600 milligrams daily. Current consensus recommendations advise that disopyramide be initiated in the hospital to allow for monitoring of the QT interval, which can be prolonged in a minority of patients where it should not be used. Prominent symptoms include anticholinergic side effects, which can limit its tolerability. This includes dry mouth, constipation, and urinary retention. Because it is a sodium channel blocker and can actually reduce the rate of atrial flutter and atrial fibrillation, and cause rapid conduction through the AV node of these arrhythmias and dangerous ventricular response, disopyramide should be used in conjunction with a beta blocker or calcium channel blocker for their AV nodal blocking properties. As mentioned earlier, surgical myectomy is an acceptable and effective therapy for patients with medically refractory symptoms related to hypertrophic obstructive cardiomyopathy. Patient selection beyond medically refractory symptoms should include the presence of severe left ventricular outflow tract obstruction, generally considered greater than 50 millimeters mercury at rest or with exercise. Patients should otherwise be good operative candidates without severe comorbid illness. And if a patient also happens to require a concomitant cardiac operation, such as a valve procedure or coronary surgery, septal myectomy is a particularly good choice. From a procedural standpoint, this operation is accomplished through a sternotomy, a midline sternotomy, incision through the aorta with visualization of the aortic valve, and resection of a rectangular section of septal muscle, leaving behind a trough which extends from the base of the heart to mid-ventricle. This is accomplished with intraoperative transesophageal echocardiographic guidance. The images on this slide demonstrate a good outcome with septal myectomy. The 2D images on top, taken from transesophageal imaging, reveal SAM, or a contact between the anterior mitral leaflet and the thickened interventricular septum during systole, as highlighted by the 3 arrows here. This is associated with severe outflow tract obstruction with a gradient across the left ventricle through the outflow tract exceeding 100 millimeters mercury. In this patient with medically refractory symptoms, after myectomy, the trough is clearly visible and SAM is no longer present during systole. Associated with that, there has been complete amelioration of the outflow tract gradient, which had previously been over 100 and is now 10 millimeters mercury, or essentially physiologic. So, in a nutshell, myectomy effectively abolishes left ventricular outflow tract obstruction. That one example is representative of the collective experience with septal myectomy for symptomatic hypertrophic obstructive cardiomyopathy. 3 large surgical series reported similar experiences over an era ranging from the late 70s to the early 2000s. It's notable that in these series, the average patient undergoing the operation was in their 5th or 6th decade with severe outflow tract obstruction at rest and near complete amelioration after myectomy. Operative mortality was low in these series with excellent 1, 3, and 5-year survival. The requirement for reoperation is generally felt to be low, less than 5%, and the most common complication is that of complete heart block, which requires placement of a pacemaker. The risk of a post-myectomy heart block is significantly higher in patients with a pre-existing right bundle branch block, as nearly all patients develop a left bundle branch block with myectomy, and the combination of 2 will result in complete heart block requiring a pacer. The alternative to septal myectomy in patients with medically refractory symptoms is an alcohol septal ablation. Like a septal myectomy, patients are selected on the basis of having medically refractory symptoms, severe outflow tract obstruction, and importantly, should have a reasonable amount of bulk in the interventricular septum to tolerate less controlled loss of septal thickness. Perhaps another consideration for alcohol septal ablation are patients who are otherwise poor operative candidates and unable to undergo a midline sternotomy, cardiopulmonary bypass, and mechanical ventilation. From a procedural standpoint in alcohol septal ablation, after coronary angiography excludes coronary anomalies and septal perfusion is established with contrast echo, injection of pure alcohol into a septal perforator follows, which leads to a controlled infarction. Because of a risk of both heart block and ventricular arrhythmias in the subsequent 5 to 6 days, patients remain in the hospital over that period of time. These still coronary angiography images published by Dr. Pfeiffer in Circulation demonstrate the characteristic findings pre and post ablation, with the septal perforator clearly visualized here with the arrow and with magnification after septal perforation occlusion, perforator occlusion, we can see the absence of flow down that blood vessel. In order to assist with confirmation that alcohol will be injected to the appropriate septal perforator, often echo contrast is used to verify the territory of perfusion. A similar appearance is present after alcohol injection with hyperenhancement on echocardiographic images of the infarcted territory. As with septal myectomy, our experience with alcohol septal ablation comes from large case series, but not from controlled studies. These large case series present similar numbers with similarly aged patients who had severe outflow tract obstruction to begin with, and reduction post-alcohol septal ablation, however, not nearly the extent of amelioration seen with septal myectomy. It's worth noting that procedural mortality occurs, and in-hospital ventricular fibrillation and tachycardia is also an observed complication. Although not reported in all of these series, 1-year survival is generally good following alcohol septal ablation, with again the requirement for a permanent pacemaker being the most likely complication. And in contrast to septal myectomy, the risk of post-ablation heart block is much higher in patients with previous left bundle branch block, as a septal myectomy usually causes a right bundle branch block. A major consideration in the management of HCM is preventing sudden death. This requires risk stratification and preventative measures. We know of sudden death in HCM as being perhaps the most common cause of sudden cardiac death in young athletes, and because of that, it maintains fairly high public appreciation. A number of risk factors have been identified at predicting patients who are at increased risk for sudden death. I've highlighted in red those which have been seen in the most series and are felt to convey the highest risk. This includes a history of syncope, in particular syncope that is not vagal-mediated syncope and has occurred within the past year. A family history of sudden death, particularly sudden death occurring at a young age in somebody who has hypertrophic cardiomyopathy, and in patients with extreme hypertrophy or maximal wall thickness in excess of 30 millimeters. Other risk factors include non-sustained ventricular tachycardia. Patients who've had a history of sustained ventricular tachycardia are felt to be at particularly high risk. Left atrial dilation has recently been established as a risk factor. Patients with a hypotensive response to exercise and late gadolinium enhancement on MRI may be at additional risk, but the use of these biomarkers of increased risk continues to evolve. In order to assess the risk of sudden death in a patient with hypertrophic cardiomyopathy, we perform a careful history, reviewing for syncope and a family history of sudden death, an echocardiogram to assess for extreme wall thickness, ambulatory electrocardiographic monitoring or a Holter monitor to assess for non-sustained VT, and an exercise test to assess for a hypotensive response to exercise. The American Heart Association and the American College of Cardiology recommend that patients with the highest risk, with major risk factors, those listed in red, are at highest risk for sudden cardiac death. The European Society of Cardiology advises quantification of risk for sudden death using a risk calculator that is widely available online and utilizes a multivariable regression model. What was previously appreciated and has been reinforced through the European Society of Cardiology Sudden Cardiac Death Risk Score is that risk factors for sudden death increase the risk in HCM patients in an additive fashion. That risk score allows the quantification of risk over a 5-year period of time based on the number of risk factors present and the age of the patient. And in a recent validation study, the European group led by Dr. O'Mahony showed that patients at the lowest risk, with a calculated risk of less than 4% of sudden death in 5 years, had a very low observed risk in a validation cohort. That patients in the intermediate risk had a modest but not significantly increased risk of sudden death compared to the low risk category. And the patients at the highest risk had a marked increased risk of sudden death in this validation cohort. It's also worth noting that the minority of patients with hypertrophic cardiomyopathy fall into the highest risk category. So how do we manage sudden death risk in patients with hypertrophic cardiomyopathy? We can follow the ACC-AHA guidelines or the European Society of Cardiology risk stratification model, and based on that, can make a recommendation for whether or not a primary prevention ICD should be advised. The ESC advises that a primary prevention ICD be considered in patients in the highest risk category and be considered as a 2B recommendation in those in the intermediate risk category, but generally not advised in the low risk category. These patients are candidates for a primary prevention implantable cardioverter defibrillator, or ICD. Of course, any patient who has experienced sudden death or had sudden sustained VT in the past would benefit from a secondary prevention ICD. It's also worth noting that medical therapy has not been shown effective nor is extensively studied in hypertrophic cardiomyopathy. So the question of sudden death prevention is ultimately one of a question of ICD implantation for primary prevention. Historically, we've advised patients with hypertrophic cardiomyopathy to abstain from competitive sport, and the Bethesda guidelines have provided some guidance as to which athletic activities should be avoided and which are generally considered safe. However, these recommendations are being reappraised, and a number of large studies should fill in the gaps as to what would be considered safe levels of exercise and competition for patients with hypertrophic cardiomyopathy. However, in the current setting, avoidance of competitive sport is advised. Beyond the individual patient with hypertrophic cardiomyopathy, an invariable consideration is their family in this disease characterized by autosomal dominant inheritance, such that 50% of first-degree family members are at risk for the same disease. Recognizing age-dependent penetrance, or the delay between fertilization and the presence of the disease allele and the ultimate development of the phenotype, we advise that all first-degree family members be screened with echo and ECG, and that screening occur on a longitudinal basis, as patients with normal cardiac morphology early in life may go on to develop hypertrophic cardiomyopathy later in life. And the frequency of longitudinal screening varies on the age of the family member, with the highest density of screening in adolescent through young adulthood. Genetic testing, however, can allow more efficient screening by identifying the disease-causing allele in the proband or index case, and then determining which family members carry this so that screening can be concentrated in them. Moving on to a different cause of thick hearts, amyloid heart disease. This is the quintessential infiltrative cardiomyopathy. Amyloidosis, like hypertrophic cardiomyopathy, is characterized by increased wall thickness. However, in amyloidosis, this is generally present as concentric LVH with normal or reduced LV cavity size. At times, this may mimic hypertrophic cardiomyopathy. However, a key distinguishing feature compared to HCM is decreased amplitude of the QRS morphology, or decreased voltage, which in contrast in HCM is increased. Patients may also be identified as having amyloidosis underlying their thick heart using MRI, and in the case of amyloidosis caused by TTR or transthyretin forming amyloid fibrils, technetium-99 pyrophosphate scans can be diagnostic. Diffuse myocardial involvement is readily apparent by biopsy. However, extracardiac pathology can be diagnostic, and utilizing multimodality cardiac imaging, the majority of patients can be diagnosed without resorting to biopsy. The three major subtypes of cardiac amyloid are AL, which is caused by a plasma cell dyscrasia and is sometimes known as primary amyloidosis. This disorder is characterized by markedly poor prognosis and often involves renal involvement. It is potentially treatable, and in the contemporary era, utilizing bortezomib or a proteasome inhibitor, as well as other chemotherapies, improvements in survival have been observed. The other two major types of cardiac amyloidosis are caused by either wild type or mutated TTR, the gene which encodes transthyretin, or the circulating carrier molecule prealbumin. In wild type TTR, this disease almost uniformly affects men above the age of 65. It is an indolent process which is often preceded by carpal tunnel syndrome and is managed principally with supportive care. However, therapies are rapidly being developed for both wild type and mutated TTR, which may allow disease modification. Now, shifting away from thick hearts to dilated cardiomyopathy. Dilated cardiomyopathy may have many different underlying etiologies, and therapy is predicated on identifying the underlying cause. Perhaps the most common cause of systolic dysfunction is coronary artery disease, and although dilated cardiomyopathy is generally felt to be that caused not by ischemic heart disease, it is important to exclude coronary artery disease with either angiography or non-invasive testing based on pretest probability. After coronary artery disease, inherited causes of dilated cardiomyopathy are likely the most common underlying etiology. This can be assessed by taking a detailed family history and performing genetic testing in selected cases. This is again present in this is the most common cause of dilated cardiomyopathy after excluding coronary heart disease. However, endocrinopathies are uniformly assessed due to their treatability, and this includes either hyper or hypothyroidism, perhaps diabetes, and that is with the caveat that causation has not been clearly established between hyperglycemia and dilated cardiomyopathy. Depending on the practice setting, infectious causes of dilated cardiomyopathy may be quite common. This includes untreated HIV/AIDS, and in many parts of the world, Chagas disease, which can be diagnosed by assessing for T. cruzi serology. Iron overload may also cause systolic dysfunction, especially in patients with hemoglobinopathies or hereditary hemochromatosis. By checking iron levels, and in selected cases, cardiac MRI assessing for T2 star or even endomyocardial biopsy, this diagnosis can be made. However, most patients with cardiac iron overload have preserved systolic function for the majority of their disease, and only later in their disease course may systolic dysfunction be present. Myocarditis is another cause of dilated cardiomyopathy to consider. Endomyocardial biopsy and MRI may be useful in making this diagnosis. However, diagnosis remains challenging due to the patchy pattern of myocardial involvement, which renders biopsy insensitive in some cases, and the nonspecific nature of findings present on MRI. Another way of approaching the differential diagnosis of dilated cardiomyopathy is with the end diagnosis in mind. And here I provided the categories of idiopathic, familial, inflammatory, infiltrative, as well as other etiologies, including those associated with pregnancy or peripartum, infectious, endocrinopathy, post-radiation, and associated with toxins. Part of the rationale for doing this is that prognosis depends in large part on underlying etiology. These survival curves come from a seminal publication from the Hopkins Cardiomyopathy Program showing the difference based on underlying etiology. Another reason to think about this is that it can help guide which patients benefit from undergoing an endomyocardial biopsy, which are highlighted here in red. Those include patients in whom you consider inflammatory etiologies, including sarcoidosis, giant cell myocarditis, lymphocytic myocarditis, potentially those with iron overload, although that is a diagnosis which can be made non-invasively in most cases, and also with certain types of chemotherapy complications, but also one that doesn't always require an invasive diagnosis. The American Heart Association has provided some guidance as to which patients with new onset DCM should undergo biopsy, and generally it's advised for patients with fulminant acute heart failure that is not responsive to usual care, or DCM with associated sustained or symptomatic ventricular tachycardia or high-grade heart block, as this can identify patients most likely to have an underlying myocarditis, especially sarcoid and giant cell myocarditis. Another reason to think about the underlying etiology beyond natural history and who should have a biopsy is that several of these have specific therapies. For several of the inflammatory or myocarditis, anti-inflammatory therapies with corticosteroids and more can be effective. With cardiac iron overload, chelation therapy or phlebotomy can be effective. And in some, at some stage of disease, Chagas disease treatment with antiparasitic therapy may be effective. And control of hyper and hypothyroidism and pheochromocytoma, the endocrinopathies which may cause dilated cardiomyopathy, can also resolve systolic dysfunction. So focusing on myocarditis, it's useful to think about that caused by infection and those that are multifactorial. Chagas disease, as mentioned earlier, is one of the most common causes of dilated cardiomyopathy in certain parts of the world, in particular where T. cruzi infection is endemic with the Regevid bug as the vector. This includes Central and South America. The associated DCM with Chagas disease is chronic and indolent with associated ventricular aneurysms, conduction disease, and arrhythmia. It's diagnosed by serology in patients who have had a relevant exposure history. And as noted earlier, antiparasitic therapy with benznidazole may be effective, especially if used early. However, when used later in the disease course, outcomes have not been generally effective. Outside of infectious causes of myocarditis, the multifactorial etiologies include lymphocytic myocarditis, which can be diagnosed by endomyocardial biopsy, and while it has a fulminant presentation, the prognosis is actually good, and clinical trials have not shown an effect with anti-inflammatory therapy, and patients are instead treated with supportive therapy, versus giant cell myocarditis, which has a fulminant course but a bad prognosis, where immune suppression may be effective and urgent transplant referral is strongly advised. And sarcoid heart disease, which may be indolent and in the setting of systemic sarcoid, is present in approximately 1/4 to 1/2 of patients, depending on the method of ascertainment. Up to 5% of patients with sarcoidosis may have it limited to their heart, and this too is treated with immune suppression and early consideration for ICD placement for sudden death prevention. As mentioned earlier, dilated cardiomyopathy may indeed be predominantly a genetic disease. The appreciation of this phenomenon has grown with different methods of assessing for genetic or hereditary involvement. Historically, dilated cardiomyopathy was not appreciated to be a hereditary or genetic disease, and this was largely because early studies utilized retrospective chart reviews for case finding. However, when prospective pedigree construction was performed, and then combining careful family history with echocardiographic screening of first-degree family members, up to 30 or 40% of previously considered idiopathic DCM is recategorized as familial. From these families, we've learned that the inheritance pattern is typically autosomal dominant, and as is the case with hypertrophic cardiomyopathy, penetrance is age-dependent with variable clinical expression. This cartoon highlights the complexity of the underlying genetic etiology of dilated cardiomyopathy. Where hypertrophic cardiomyopathy was a disease principally of the sarcomere, dilated cardiomyopathy may have many more underlying mechanistic underpinnings. It includes mutations in sarcomere genes, but may also include cytoskeletal mutations, mutations in genes which encode the nuclear envelope, and genes which are important in RNA splicing. Over 40 putative gene associations have been made, but supportive causation is limited for all 40. In brief, 40% of patients with so-called idiopathic DCM have genetic disease, and genetic testing is now available in clinical practice, with the most commonly mutated gene being TTN, which encodes the giant muscle protein titin. So in summary, most patients with symptomatic hypertrophic cardiomyopathy can be effectively managed with medications, but septal reduction therapy is highly effective in patients with left ventricular outflow tract obstruction and medically refractory symptoms. Sudden death risk stratification in hypertrophic cardiomyopathy is a multimodality process, and shifting from HCM to DCM, definitive diagnosis of the underlying disease can have therapeutic ramifications, and inherited and familial disease is the most common cause of DCM. Moving on to questions. Which of the following features do not portend an increased risk of sudden death in HCM? Is it A, a family history of sudden death? Is it B, non-sustained ventricular tachycardia during an exercise test? Is it C, syncope? Is it D, hypertensive response to exercise? Or is it E, reduced LV systolic function? The characteristic which is not predictive of sudden death is a hypertensive response to exercise. Indeed, it is a hypotensive response to exercise which may be a risk factor for sudden death in hypertrophic cardiomyopathy. Which of the following statements regarding management of left ventricular outflow tract obstruction is true? Is it A, patients with severe obstruction in excess of 30 millimeters mercury exercise should be referred for surgical myectomy regardless of symptoms? Is it B, alcohol septal ablation is associated with a lower risk of peri-procedural mortality than surgical myectomy? Is it C, AV block requiring permanent pacing is a frequent complication of both surgical myectomy and alcohol septal ablation? Is it D, disopyramide is first-line medical therapy for symptomatic outflow tract obstruction? Or is it E, RV apical pacing is an effective alternative to surgical myectomy? Which of these is true regarding the management of outflow tract obstruction? It's C. AV block requiring permanent pacing is a frequent complication affecting 5 to 20% of patients undergoing surgical myectomy or alcohol septal ablation. Approximately what percentage of patients with non-ischemic dilated cardiomyopathy have evidence of hereditary disease? Is it A, 5%, B, 10%, C, 35%, or D, 75%? It is felt to be approximately 35% when utilizing best methods, including echocardiographic screening of first-degree family members and prospective pedigree